going to do. We're even going to put you up on YouTube if you don't object. All right.
Ready to go?
Yes, sir.
Here we go. I think here we go. Let's see. There we go. To start off with, let me say that the vast majority of serious nerve injuries usually leave the nerve in some degree of a continuity. Now that presents surgeons with a problem, because what are you going to do about it? What do you do to fix a nerve lesion in continuity? The problem here is that in the past, most of the decisions that surgeons have made have been intuitive. You basically look at a lesion in continuity and you think, well, I think this is probably what I'm going to do here. Inspection alone can be very deceptive. You can look at lesions in continuity and be very, very wrong about your appraisal of that injury. Even when you use magnification and you can look through the epineurium and see gross fascicular continuity inside of that nerve, that does not guarantee integrity in that nerve. The problem too with stimulation is that by itself, stimulation may not be useful until nerve fibers have actually regrown and reconnected with muscle. In that case, it takes many months. There is a lot of time wasted if you wait for that regeneration to occur. What Dave Klein really initiated was the process of doing operative recording. And in this case, you can get an early indication of regeneration. In this case, you save a great deal of time and you improve the statistics about recovery of motor function. Connection with muscle is not necessary in this case because you are stimulating nerve and recording from nerve. This particular process is especially valuable for traumatic injuries. You get information about a nerve injury that is not available by any other method. It is pretty quick, pretty simple, and once you establish a protocol for doing this, it's a pretty easy process. You get an indication of the functional status of the length of nerve that you are looking at. So you, in essence, are looking at a discrete lesion when you expose a length of nerve that has a lesion in it and you stimulate and record across that lesion. Decision-making, when you do this, is no longer intuitive. You have hard information to work with. It is accurate. We have done, we did an appraisal recently of the number of cases that we've done over our entire careers, and there's been well over 20,000 cases that we have done making these recordings. Under these circumstances, when you have good information to make good decisions, you get the best possible outcome for the patient. In the past, people have used stimulation and observing motor function as an endpoint to determine whether or not there is integrity of motor nerve fibers. This is something that can be very misleading, and I'll give you a specific example of this. I got a call from a neurosurgeon one time in Toronto, and here I am in New Orleans, telling me that he had a 7-year-old child that had a flail arm from birth, and he was stimulating elements of the brachial plexus, and he was seeing movement of intrinsic hand muscles. And this child had no voluntary motor function. The child had a flail arm. How can this possibly be? Well, what happens when you stimulate a section of nerve like that is that you can synchronize many, not many, but a few very small motor units. And when you synchronize them all with the same stimulus pulse, you can get 6 or 8 motor units to all fire together and produce visible movement, and yet the person would have no voluntary motor function because those motor units are too small to produce voluntary motor function. The compound nerve action potential is much more reliable than using motor function as an endpoint. Now, here are some examples of experimental lesions that we made in monkeys. And what we see here on the far left top, I don't know if you can see my cursor here or not.
Yes, we can.
You can, great. Okay, in this slide, what you see is what looks to be a neuroma in continuity. And that neuroma in continuity in the past would have caused the surgeon to say, probably the best thing to do intuitively here is to resect this lesion and do a repair of that injury. By contrast, here is another injury that we placed in a primate that doesn't really look too bad. And you might think the best thing to do here is let this alone and see if this will spontaneously recover. Unfortunately, if we look at the histology of this, the histology of this one is seen below, and you see good longitudinal connectivity of axons. That same piece of nerve is illustrated here, and what you see is that the scar is primarily in the epineurium. There's a lot of fascicles in this nerve that are intact. You would do this patient a great disservice to cut this nerve and to try to do an end-to-end repair on that kind of injury. By contrast, with this injury, we section it, and what we see is a lot of derangement of the internal connective tissue compartment of nerve. Over here, you don't see much longitudinal connectivity of fibers in that lesion. Leaving this lesion alone for any significant period of time would not do the patient a favor. The patient is not likely to recover spontaneous function from this injury.
Can I ask you a question on how you created those injuries? What was the mechanism for the monkeys?
Yes, these were compression injuries or crush injuries. So the injury over here was a compression injury, actually a very mild crush, and this was a severe crush.
Okay.
So visual inspection, we have 2 examples of here of how this could be misleading. Now, let's look at what happens when an axon is insulted in some way. Let's start off with a neuropraxic injury. So if I perform a neuropraxic injury, perform a very mild injury here that is neuropraxic, what happens is there is a functional loss, a functional loss of conduction in the axon. And so when this happens, the axon remains intact, distal to the neuropraxia, the fiber would be intact. So if you were to stimulate distal to a neuropraxic injury, you would see movement. Movement would occur. If you did nerve recordings, you would see a nerve action potential. And so obviously this is a very mild injury, and usually this kind of injury will recover spontaneously. Let's start now with an axonotmetic lesion. We're going to section this fiber. What happens when you cut an axon? Well, the first thing that happens is in the next section here, there is a lot of macrophage invasion, and all of the cellular debris is cleaned up. But there is an axonal sprouting process that will take place. From one single cut axon, what will happen is 15 to 20 or so small fibers will begin to emerge from the proximal stump of a cut axon. These fine fibers will grow in length, and sometimes that length can be quite considerable. They will grow in length, and in order for good functional recovery to occur, some of these branches of fine fibers coming from one proximal stump have to die back. Only if those die back can the distal axon here increase in caliber. These fine fibers will never make good motor end plates. They will never make good functional motor recovery because the motor end plates are too small to really make muscle work. By contrast, the bottommost axon here that has grown back will be large enough to make some large motor end plates, and motor recovery can occur. That final slide, E, also demonstrates the fact that distal to a point of injury, the axon, as it regrows, will never achieve the same cross-sectional diameter as the proximal part of the axon. That means that the number of motor fibers that this smaller diameter axon will connect to will be less. Another way of saying the same thing is that the reconstructed motor unit from this regrown axon will always be smaller than the proximal axon as it existed. It is important to identify when the process of regeneration begins and when it's taking place, because there is a finite window of opportunity for regeneration to occur. This window of opportunity is usually a little bit larger for children than it is for older patients, particularly elderly patients. So we always give children a little bit more benefit of the doubt when trying to determine whether or not a peripheral nerve repair would be worthwhile. So we have some slides here that just illustrate the fact that our primate studies, our primate recordings were done in vivo on lesioned nerves that had been placed previously. And we used primarily crush injuries, but also some sever and suture injuries. The positive nerve action potentials that we recorded from some of these injured nerves, the EMG recordings, successful EMG recordings, preceded functional recovery by a considerable period of time. When we did not ever get good compound nerve action potentials, this correlated with a very poor recovery. Now, the last point here is worth emphasizing, and that is when we recorded a compound nerve action potential in a recovering nerve, the presence of a compound nerve action potential required approximately 4,000 fibers greater than 5 microns in diameter in order to produce that compound nerve action potential. So these 4,000 fibers, 5 microns in diameter or better, will produce some good motor recovery.
So back to your prior slide where we're talking about the little tiny neurites that are sprouting from these severed axons. Are they greater than 5 microns?
No.
Yeah, so don't they have to reach a target before they take on that caliber?
They will have, well, yes. The issue is they will have, some of them will have to die back. It's the dieback, the relationship between the cross-sectional diameter of the proximal stump to the sum of the cross-sectional diameters of these fine fibers is usually going to be pretty much the same.
Okay.
So as these die back, that's when the axons, the remaining axons, will increase in caliber. let me just give an aside here. I have had the privilege of watching an axon grow under a phase contrast microscope in tissue culture. It is a fantastic process to watch. It looks kind of like a cobwebby kind of process that's emerging from the proximal stump. And as it proceeds in length, it consolidates into a round little neurite.
So do you think that once they find a healthy endoneurial tube, they begin to prune some of those neurites that haven't found an endoneurial tube, and it begins to take its caliber on? So it doesn't necessarily have to hit a target, but it has to find a nice Schwann cell filled pathway that it can work its way down.
Well, in order for the fiber to begin to grow, it doesn't really need anything.
Right.
You can have an axon grow into a slab of gelatin.
But for it to take on the caliber, so, you know,
Yeah.
moving from the tiny neurites to the larger caliber axon, do you think it can do that just by finding a good endoneurial tube?
Here's a really good point. The growth of axons is stimulated by chemical messenger molecules.
Yeah.
And those messages are almost like Schwann cells screaming out, "Where the hell are you?" And so that kind of stimulates the axon to grow. We think that there may be different messenger molecules for afferent as opposed to efferent axons. And so there may be some preference for axons to grow into an appropriate cylinder for either a motor or a sensory fiber. But this is kind of controversial yet. The story's not answered on that just yet.
Right.
Here's a compound nerve action potential. This is something that is very easily measured. It's something easy to see. It is a measure of the functional integrity of a section of axon. It localizes function. You can say definitively that when you see an action potential such as this, that length of axon is functional. And I would mention that you have to have that caveat of fine fibers. Fine fibers are only an early stage of regeneration. And if the regenerative process doesn't proceed, all you get is fine fibers and there is no functional recovery. The case that I referred to about the child that had fine fiber growth, where we were synchronizing fine fibers and producing visible contractions of intrinsic hand muscles, you have to treat that as a complete injury. That injury had to be resected in order to give axons a second chance to regrow in sufficient caliber.
So I would imagine then that neuromas are primarily made up of fine fibers. The axon
Yes.
component. Yeah.
Yes, the neuroma story is another story. I spent a good part of my career looking at neuromas. Sir Sidney Sunderland asked a rhetorical question in the middle of a lecture. He looked me in the eye and he said, "What is the difference between a neuroma a neuroma that is painful and a neuroma that is not painful?" And I spent about 20 years trying to answer that question. And so the answer, the bottom line is how a particular individual's body responds to injury. The deposition of channel protein molecules, sodium and potassium channel protein molecules into excitable membrane is extremely important in making that determination. Those neuromas that become painful contain vast quantities of sodium channels. And those sodium channels become ectopic generators of action potentials. And those ectopic action potentials are the source of pain for those patients. But anyway, here's a nice recording, and it shows a number of points here that are probably pretty important. Here's a section of nerve in an upper arm where we have median and ulnar nerves side by side. This arrangement gives us the opportunity to have a control. We have the ability to test two segments of nerve. In this patient's case, the ulnar nerve was damaged and the median nerve was not. So when we placed stimulating and recording electrodes on median nerve and then look at the recording here, tell people, I think even Stevie Wonder could see this compound nerve action potential. This compound nerve action potential has very nice features. It is compact. That is to say, it is short in duration and it has good amplitude. The amplitude is an indirect indicator of the number of fibers in the nerve that you are dealing with. The width of this is an indication of the distribution of conduction velocities in that section of nerve. So if this is normal, let's look at the ulnar nerve. What we see here from the ulnar nerve is that it's not as tall, it's shorter in height. That's an indication that there are fewer fibers in it, and it is very dispersed in its duration. That's an indication that there's a wide distribution of different conduction velocities in the fibers that compose that nerve. So yes, this is a good indication that there's a lot of sick fibers in this length of nerve. This is a section of peripheral nerve that probably is a little bit more accurate. What we see here relative to some of the illustrations that we see of mouse or rat peripheral nerve is that there is a lot more connective tissue in human peripheral nerve.
Yes.
Unfortunately, what you cannot see in this illustration is all of the messenger molecules that will come from many of these connective tissue cells, the fibroblasts, all of the connective tissue cells that will release messenger molecules in the event of injury. But the purpose of including this slide is to illustrate the fact that people often call some nerve injuries partial nerve injuries, to reflect the fact that clinically the patient may have some symptoms of a nerve lesion, but not all function in that nerve is lost. And so they call that a partial nerve injury. I kind of don't like that terminology because it carries the implication that some of the fibers are normal, whereas other fibers are very abnormal. That's not the case in a nerve injury like this. I prefer to call this a mixed nerve injury, where we have, in fact, some fibers that are affected much more than other fibers. And so when we deal with this as a nerve injury, we may have to treat some fascicles, some parts of this nerve differently than we would treat other parts of the nerve. Operative studies using stimulation and recording can be very helpful here. And we can actually open the epineurium, dissect out individual fascicles, and stimulate and record from individual fascicles, and in that way determine which fascicles are working better, which fascicles are not working as well. Here is an indication of a mixed nerve injury where we have some fascicles. This little fascicle can be seen to have a little neuroma on the end of it, and some of these others as well. So when you split the epineurium and you pull these fascicles out, you can actually see that these fibers have been interrupted, and they will have to be either repaired or grafted. This is just an illustration of the fact that we recorded from a large number of entrapped nerves, and these entrapped nerves responded to release and recovered pretty quickly. Here's a good example again of not being able to judge a book by its cover. Here we see on the left a huge neuroma, and this neuroma is in a portion of the nerve. Whoops, I can't use that arm, sorry. That arm not working so good. I don't know what happened to my cursor, but in any case, on the left-hand side, there's a large bulbous neuroma that is a part of the nerve. And in this case, resecting that large neuroma from just that fascicle proved to be the answer to this patient's problem. Above, you see the fact that we had, here we go, we had good recordings, and the recordings proximal here showed us the normal pattern where we had a nice compact compound nerve action potential that was tall and indicated lots of fibers. That's when we stimulated and recorded proximally. When we move across the lesion, you see that there is a large shift in time, indicating that the conduction velocity had fallen, and that was because of the compromise of the fibers there. So resecting this lesion and repairing it produced a good result. On the right-hand side, we see a much bigger neurofibroma, and there was no compound nerve action potential over the length of that section of nerve. So here we see that the proper answer to this is to completely resect that lesion and do a epineurial repair on that nerve injury. Example of an image that shows a neuroma, a large neuroma in the upper arm of a patient. And this 20 years ago probably would have told a surgeon that you have to go ahead and resect this and do an end-to-end repair. And that would be the best way to treat this injury. When this neuroma was dissected out, it proved to be not really a neuroma, but a myosarcoma. It was actually a muscle tumor that had invaded the nerve. And so resecting this very large tumor produced a good result, because even though this was a large lesion, stimulating and recording across this lesion produced good indications of a compound nerve action potential. And so we knew that, that this had to be left alone and just remove the lesion. The nerve fibers remain. Again, just these are numbers, but when we look at all of the numbers and we look at the statistics and we evaluate our statistics indicate that we improve outcomes by stimulating and recording across lesions and using that as hard information to discriminate which lesions will respond best to a conservative treatment of neurolysis and removing scar tissue, as opposed to removing a lesion and doing an end-to-end repair. This is a flow chart of steps that you can perform in making recordings that will confirm whether or not there are intact fibers. And I'm not going to go through this, but if anybody is interested in this flow chart, I can furnish it to Dr. Brown, and Dr. Brown can distribute that to anybody that would like to have that.
Sure, I can't read it from here, so tell me.
And in that case, I'll have to email you something that you can use.
Perfect.
The conclusions to all of this is that operative nerve action potentials can document. It's hard information. It's proof of the presence or absence of nerve function. You are making hard decisions based on good evidence rather than just intuitive decisions. These NAP recordings can document useful regeneration. So looking at a nerve lesion longitudinally can give you good information about whether regeneration is in progress. These NAP recordings can be helpful with entrapments as well as traumatic lesions or as well as nerve sheath tumors, a whole variety of pathology can be assessed by using these operative recordings. I did want to leave some time for questions, so we'll open the floor for questions if anybody has questions.
Yeah, thanks very much, Dr. Happel. That was great. I'm a neurophysiologist working with Dr. Brown, so I'm very interested in this type of stuff. And I was curious about whether you can get an estimate of the quantification of the number of axons from the. Sorry, we got a massive leaf blower going on outside our window here.
Yeah, the figure that I gave was if you can see a visible compound nerve action potential, and this visible compound nerve action potential would have an amplitude greater than 20 microvolts. If it's got an amplitude of greater than 20 microvolts, you can usually see this without using any of the fancy computer averaging techniques that are available. In fact, I would really discourage people using computer averaging techniques because that increases the sensitivity so much that you can be misled into thinking that you have a nice large compound nerve action potential when in fact it is minuscule. But if you have a 20 microvolt compound nerve action potential, you will have approximately 4,000 fibers of 5 micron diameter or better.
So that is not the C fibers and the A delta fibers. That's the
No, your C fibers would be 1 micron or less.
Yeah, and would you be able to quantify even further? So if you have a 200 microvolt amplitude versus a 100 microvolt amplitude, are you saying there's essentially 50% of the number of axons?
Yes. If you have a 100 microvolt amplitude compound nerve action potential, you've got a lot of fibers. And usually those will be large fibers because if all of the fibers have approximately the same conduction velocity, they will add together in a more efficient way to make a taller compound nerve action potential. And that happens when you have large diameter, heavily myelinated fibers. The conduction velocity doesn't vary very much at all.
Did you manage to look at the amplitudes and correlate to the number of large fiber axons? So 200 equals so many thousand axons, 100 equals so many, 50 equals.
We've never done the large numbers. We were more interested in defining what the small number was. So the small number would tell us this is worth saving.
Yeah, it's like the equivalent of a multi-unit number estimate on the nerve action potential, a nerve estimate, nerve axon estimate in a way.
Yeah, the equipment that you use, by the way, is very, very important. And I would advocate anyone who chooses to incorporate this technique of operative recording of compound nerve action potentials, please make sure that you are using the appropriate equipment. The equipment today that is commonly used in operating rooms is optically isolated stimulation and optically isolated recording. Using that kind of instrumentation minimizes stimulus artifact. Stimulus artifact can be a substantial problem. if you're not using the right kind of equipment.
And let me ask you, when I'm doing just motor stimulation in the operating room, obviously if you have cleaned the perineurium off of the nerve, you're going to have a bit more sensitive, more robust response. You can dial down your amplitude. Once you've opened the epineurium and now you have your intravesicular, you have your fascicles stripped free of the connective tissue, suddenly your threshold drops dramatically and you get a very robust response at a very, very small amplitude. Would you likewise see similar change in the amplitude of the nerve action potential based on how much connective tissue is around the site of stimulation?
Generally, the electrical stimulus that we use is supramaximal.
Okay.
And so if it's supramaximal, there's not that much difference with extra connective tissue. Now, I will say this, intracranial portions of the same nerve, like facial nerve, if you're considering the intracranial portion of the facial nerve where there is much less connective tissue, you are stimulating at fractions of the intensity that you are using to stimulate the extracranial portion of the facial nerve. I have never seen anyone damage a peripheral nerve or even a cranial nerve for that matter,
Yeah.
the fibers of the cranial nerve anyway, by stimulating supramaximally.
And again, the size of that nerve action potential, if you were stimulating intracranially or extracranially and not requiring the same amount of stimulus, the size of the response would still directly correspond with the number of axons and not how sensitive the stimulation.
That's correct.
Okay.
That's correct.
Would you be able to do a similar technique with needles and guiding in the needles in the clinic with ultrasound and trying to get nerve action potentials that way? Is that something you've tried?
We've never really tried using needles in the clinic. In the clinic, what we have chosen to use is the process of signal averaging. So placing skin electrodes and doing signal averaging takes care of filtering out noise and creating an effective amplification that is much greater. So we don't really need to have needles. Now, I will say this, we use hook electrodes when we do stimulating and recording on a section of nerve. But there is one very good neurosurgeon that simply took needles and stuck needles in the nerve and claimed that he had never seen any indications of damage to the nerve by sticking a 27 gauge needle into a peripheral nerve to use that as the recording electrode.
Right. Hi, Dr. Happel. This is Reiner. I'm a neurologist that works with Dr. Brown as well inside the operating room. And I thank you for your work with David Klein. I always will go back to your publications during cases, those that were like back in 2009. And I agree with you. Nowadays, we've been using tripolar stimulator and to reduce stimulation artifact using, and then averaging less so that we don't amplify potentials. I have a question. How do you, as you were showing in your previous diagram, having a good control is usually the most ideal setup. How do you, if there's no option for a control, what would be your suggestion? To verify that there's no responses or no recordable potential, and and also you like other intraoperative neurologists, they always say recording CNAP seems to be you present it in an easy way, and I agree, but actually it's practice, and I appreciate Dr. Brown and all the other surgeons who've allowed me to continue to do several trials, because ultimately it's the more you do it, the more easier it gets. But I think the problem is usually the variables inside the operating room, and then getting a good control before testing aside for the lesion nerve.
it's kind of like every new technology that you bring into the operating room has to confirm its credibility. And so if we are going to place credibility in these compound nerve action potentials, we need to become familiar with it. The more familiar you become with it, comfortable you are with accepting the findings from that. When you're starting out, it's nice to have a control nerve that is right next to the nerve that you're interested in, but that doesn't always work out. So as I say, the more recordings that you make and the more you use the same equipment and the same techniques, the more confident you become in the findings from your stimulation and recording studies.
Hi, I'm Jorge Clifton from Mexico, and thank you, Leo, for this wonderful lecture. I have used this this technique of nerve action potential several times. I found it very useful when we have gunshot wounds that there's a mixed function, and also in nerve injuries secondary to fractures. When there is like a really bad fracture that involves nerve, I find it very useful. What will be like the timeline for you? When can you do the earliest nerve action potential and the latest, I don't know, let's say?
Yeah, we usually like to do our initial recordings within the first 3 months. 3 to 5 months is really a good point for investigating a traumatic injury. And one of the reasons for that is within 3 to 5 months, if a nerve is going to spontaneously regenerate, the regeneration process will be ongoing. And so there will be enough length at 3 to 5 months that you can get distal to a point of injury and see that there are indeed growing neurites, growing fibers at 3 to 5 months. Now you mentioned gunshot injuries. One of the things that we have seen is that high velocity missiles, high powered rifles will create a different kind of injury. There is a percussion injury. There's a concussion wave that travels through tissue that has the ability to disrupt axons so that the missile does not actually have to interrupt the nerve to completely destroy the nerve. The concussion wave will compress and disrupt the axons as a source of injury.
Yes, I have used it especially in brachial plexus gunshot injuries. So you have a lot of nerves, nothing is working, but you want to know what are really injured and what can go by themselves. So I find it extremely useful, this technique.
I agree. That's something that we have found also. When you have a complex of nerves like the brachial plexus, discriminating what works and what doesn't work is very important. And this is a good, easy technique to do that.
It's the best. And what will be, great, what will be like the earliest time to do the nerve action potential?
Well, you don't want to do it too early. If you do it within 72 hours, if you section a nerve, if you actually cut a human nerve, the distal fibers can survive for as long as 72 hours. So if you try to record immediately after an injury, you could be misled by fibers that have been interrupted and will eventually undergo Wallerian degeneration, but they simply have not died yet. So don't do recordings within 72 hours of an injury.
Okay, so that will be like the earliest after 72 hours?
Yes, after 72 hours. If you wait that 3 to 5 months, though, you do allow for the window of opportunity for fibers to begin to grow. And at 3 to 5 months, they will have grown enough that you can access them, you can connect to them and see that they are regrowing. So you know, if you see regenerating fibers, you don't want to resect that lesion.
Okay, great. Thank you, sir.
And I would say, and correct me if I'm wrong, Dr. Happel, but the early recordings that you do before 4 months, you're really looking at what's residual, what's still there after the injury. Whereas if you wait after your 3 to 4 months, now you're looking at what has grown, what has regenerated past that site of injury that you're now reporting, what's going to, more anticipating what's going to take place.
Yes, you have presented the opportunity for fibers to grow. And if those fibers are growing, that's a very good positive sign.
I have used it also in shoulder subluxation, nerve injury secondary to the shoulder subluxation in patients that have like no function after 3 months. And then with this technique, I can see what nerves are going to regenerate and what are not going to use. So I found it also very useful in shoulder dislocations. And
Indeed,
yes.
I agree.
Perfect. Well, thank you very much for your time this morning, Dr. Happel. And I still do want to twist your arm to somehow get you involved in June, but apparently it's already been twisted by the doctors just yesterday. But this was really helpful. And if you don't mind, we're going to put this up. We've been capturing these talks and putting them up on a YouTube page so folks can come back and reference them in the future. And if that's all right with you, I'd like to do the same with this one.
Nice to have met you all.
Good to meet you. Take care now.
You too. Bye now.
Bye-bye.
Thank you.